Greetings. My name's Dr. Paul Davis. I'm an audiologist that specialises in tinnitus for more than 30 years. And over that time, I've had so many patients ask me the same thing. They're just overwhelmed by all these things they see online and what their GP says and what their friend says, and um, how do they get a sense of what suits them, what's the evidence for them, um, is it bunk? And unfortunately, there's quite a lot of so-called snake oil out there, but there's some wonderful things. And so I've decided that I'm going to start presenting a regular series of free videos just to help you understand what some of your treatment options might be. Um, and hopefully that can be helpful for you. Um, about every week or two, I'm going to try to present a new one on one of these questions. And the first one is going to be medications, like prescribed by a medical practitioner, or supplements, which are definitely not. And then hearing aids and neuromonics and brainwave TRX, which is something new and exciting. Tinnitus retraining therapy, cognitive behavior therapy, electrical stimulation, including the NERI device. And there's a ton more. And I want to pepper amongst them some of my snake oil file, because unfortunately there's so many of them. So I want to talk about the candidacy for them, who suits these sort of treatments, and what is the evidence available for them. My perspective is very much, though, from an evidence-based perspective, and I did a PhD in Australia, which follows the Oxford tradition of making a significant original contribution to science, so very heavily evidence-based. And so on the top of 30 years of treating tinnitus patients, I feel this sort of is sorely needed, is to be able to provide some authoritative, if I may say so myself, authoritative advice on the various options, because there's quite a lot of possibilities out there. And when there is evidence which is robust enough, I'd like to start slotting it into this way we present data and meta-analysis, which is how consistently effective treatment is, which is something which is most important to you, the person with tinnitus, or maybe one of your loved ones or one of your patients are looking at this. So it's very easy for people to say, I had this great testimonial, but that might be 1 in 200 people. But if you have 200 people having 80% of them having a significant improvement, well, that's far, far more powerful. So how consistently effective it is. So that's what I want to talk about. But before we start, today's an introduction, and I'll get more into specifics in subsequent video messages. Tinnitus is any sound which doesn't correspond with the outside sound. So that's the definition. But of course, most commonly is a ringing or a buzzing or a humming, but a whistle, cicadas, Morse code, even musical phrases is one type of tinnitus, which is quite interesting to me. But any of these constitute our neurological noise floor, our brain static. Now, everyone's got this sort of noise, but when we have good hearing, the outside sound covers it up. But when you have hearing loss, the ambient noise covers up our internal noise. But when you have hearing loss, it uncovers it. So we hear inside sounds which other people don't hear. But then when tinnitus becomes annoying, these neuroplastic, these neurological, these electrical processes cut in to amplify it. And this is why these days we can start to treat it, because that's the key point. So whatever can cause hearing loss can trigger tinnitus, and often there's a combination of factors there, but it's that neuroplasticity, that malleability of the brain, which makes it annoying, and that's what we can actually treat these days. And of course, it can become extremely annoying when you're interfering with sleep, concentration, relaxation. If you're watching this with tinnitus, you don't need me to tell you that, but it certainly can be quite a problem. That's for sure. I've seen it a lot, and I've had it tinnitus myself, which started me on this journey some 30 odd years ago. So often people think, I don't have a hearing loss, but they haven't had their hearing tested. And often it's higher than the speech range, and the speech range tends to finish at about 7,000 hertz. This is the speech banana, this shaded area. So for these higher pitch sounds, that's where, this is more than 3,000 ears that I've compiled from different studies. and most regular audiologists only test to 8,000 hertz. So commonly people have hearing loss higher than most of the speech range, so not that apparent to them if it's happened gradually, but they have very decreased sound tolerance as well, which can also obscure it. Um, so most commonly, so many people are told there's nothing you can do for it, you just have to learn to live with it, which has kind of become a self-fulfilling prophecy. Um, and that's not necessarily true at all these days. Often it's from an ENT, or which their tools are surgery or medication, and there's a small subset of people which you always look for those to be able to send them for treatment. But these days it's the annoyance we can train down, and there's some wonderful studies with MEG scans, which is electrical response to sound, or PET scans, which is cerebral blood flow, and these studies in live humans has confirmed that it's auditory deprivation that has caused the brain to turn up the sensitivity. So the hearing loss is a lack of input, which nature hates, so it tries to fill a lack of input. Always tries to fill a vacuum, of course. So it makes sense that these sorts of studies show that we can feed the brain missing sounds. It trains down the annoyance. Okay, well, the pitch of the tinnitus is critical. A lot of studies that show that generally the pitch of the tinnitus corresponds with the hearing loss frequency that's the worst hearing frequency in that sort of general region. So many studies have shown the essential nature of ascertaining the pitch of the tinnitus for working out candidacy for a lot of treatment, as well as being able to play it back so people can share it with others and whatever. And certainly a lot of rookie mistakes, i.e. non-tinnitus specialists, they often only test patients hearing up to around 8,000 hertz, which is the standard speech range. So patients don't actually get a chance to compare the comparison tones with what they hear. And like my tinnitus sounds quite a bit like 7,000 hertz. But if I hear 14,000 hertz, which is exactly an octave higher, it's like, wow, that's really it. But if it didn't test up to 14,000 hertz, I wouldn't be able to compare. So that's certainly key. Most true tinnitus specialists usually test hearing and pitch up to at least 12,500 hertz, and that's been necessary for neuromonics and for any sort of valid research, to get to the true, pitch of the tinnitus. What's more ideal is to test up to 20,000 hertz. That's ideal. It's quite rare, but I have that because it's so critical. So we know exactly the nature of the tinnitus, and it's essential for my new brainwave TRX. So if you want to hear something like my tinnitus, this is the one. It's like a furry ring, and this is very common. It's like a narrow sound with a pure component, and this is certainly what got me started on this whole process as an audiology student. Now it's way back in the background, but this is a very typical sort of tinnitus sound. But I needed to recreate it by measuring all those frequencies. Of course, I can turn it off. It's quite different to the experience of having it going constantly, but I'll turn it off. So nearly everyone has tinnitus if you put them in a quiet enough room and wait long enough, and people start to report it, but not straight away. But there's a whole continuum of severity. And so in terms of the incidence of it, it's the moderate to severe people, which are the main ones who end up in the tinnitus clinic. And there's a range as well. Some people are more preventative and try to get to it early, which is always a good idea. Or hyperacusis is a bigger problem than the tinnitus. But in terms of the incidence of tinnitus that's a clinical problem, it's at least 5% of the population is moderately affected, and at least 1 to 2% severely affected. So if we say 6.5% of the population to cover the moderate severe group, that's like more than 23 million Americans. And of course, there's a ton of other countries too, of course. So it's a very large public health problem. It's a huge one. It's the most prevalent condition in the US military. And even back in 2017, there was 1.8 million disability claimants. These days, of course, much more again. And VA clinics tend to be overwhelmed with people with tinnitus. So it's a huge problem for the military, of course, for the veterans and active service people as well too. So I certainly have enjoyed working with those people because it's something we've got a lot of work to do for. So in case you're wondering who this fellow is, um, I've got a PhD in tinnitus treatment back in 1998 and finished that, and I've received more than $2 million in research funding over the years, published more than 37 peer-reviewed papers, more than 990 citations. I was invited to write a chapter for the book Tinnitus Treatment Clinical Protocols, and the textbook of Tinnitus 9 featured invited addresses of keynote speaker, featured speaker, etc. Won the best post-award tinnitus seminar in Sweden, 2008. I was associate professor of audiology in Australia for 5 years and in the US for 9 years, and now I've been back in private practice in Australia, lecturing at Southern Cross University and working on tinnitus telecare. So just to give you an idea that's sort of what's my perspective in presenting is. So back in 1995, I was commissioned to write this self-help book, Living with Tinnitus. And this proved very popular, very accessible for the layperson. It helped me change the way I think about it. Even though back then we really couldn't do much to treat it, we were just trying to manage it. But after that, I presented various self-help workshops to people just with tinnitus, which has always been interesting, the feedback and the interaction and the therapeutic for quite some people. And I certainly love teaching other health professionals how to better manage it too. So as far as technology, I've been the inventor of more than 32 patents. I invented the Neuromonks tinnitus treatment back in 2001 or something like that. So all the patents just ran out a couple of years ago. But yeah, more than tens of thousands of patients have been successfully treated. And if I may say so, considerable scientific acclaim for the papers, especially papers that other people have done independently. There's links to that, but that's where it's come from. But ultimately, it did prove to be too expensive, the medical device, and for to be super viable. And it's been taken over by various VC groups, and they wanted me to exit to prove it was viable without the founder, etc., or whatever. And yeah, that was an amazing learning experience. So now I've got something completely different, and it's software based, telehealth enabled, brainwave TRX is what we call it. And it certainly proved to be much more effective and at least a quarter of the cost than to buy a medical device use your iPhone. So that's been exciting, and I'll be presenting more information on that later on because I've only just got patent coverage in 150 countries a couple of months ago, so now I'm able to talk about it. But in my clinic, of course, I dispense whatever is most appropriate for each patient and the hearing, their tinnitus, their lifestyle, etc. And for example, about a third of the cases in the specialist tinnitus clinic, they dispense hearing aids as their tinnitus treatment, but they're often specially programmed. I haven't spent too long on the triage because we're going to go over that over the various talks. But certainly I find if we carve up people's level of hearing loss, their level of tinnitus disturbance, like how intrusive it is, and their level of loudness tolerance, which you measure loudness discomfort levels. And from that, we can see that if people actually hearing is normal, their tinnitus isn't highly disturbing, and the loudness tolerance is normal, well, they don't need any treatment, just counselling. And to know there are options could be enough to prevent it becoming worse. So that's a great category to work with. But then we have people that hearing is not bad, tinnitus is not bad at decreased sound tolerance. Well, they're a great candidate for training down the decreased sound tolerance with brainwave TRX monitoring treatment, plus or minus tinnitus coaching, which is, influenced by CBT, plus quite a few other eclectic things. But counselling, and sometimes referred to a specialist therapist in that regard. But people with, say, quite an audible hearing loss, the tinnitus itself is actually not that annoying. People might be blaming stuff on it. Well, then, and the loudness tolerance is normal, the hearing aids are the best treatment, especially if the pitch is less than 4,000 hertz or 4 kilohertz. The largest group tends to be people that have got just a high frequency hearing loss. Tinnitus is very disturbing, normal or decreased. They're awesome candidate for brainwave. But then there are people that have decreased sound tolerance and can't cope with hearing aids. Brainwave can improve their sound tolerance. And some people you can still use neuromonics if they want, and this might be because the health insurance still offers that, or whatever. But train down the sound discomfort, then they can go to hearing aids. So that's kind of an idea, assuming we've already ruled out any of the readily treatable medical conditions. So that's kind of an idea what a specialist clinic does, have that option. So when it comes to you and you're overwhelmed with these range of options, what you've been seeing is a place offering a range of possible techniques that is one. Because I see all the time there might be acupuncture clinic and they treat everything with acupuncture. Or to me, I'd much rather go to a clinic that specialises in just in my condition and uses a range of different treatments. And I think that goes with so many health conditions. And so in my experiences, you best go to someone that specialises in the condition, not with one technique and tries to fit a lot of different conditions. That's my opinion. No matter what it is there a one-size-fits-all for treatment, or is it actually customised for your exact circumstances? Because that tends to improve the efficiency immensely. So how can we tell whether there's external validation of what people are promoting, or at least some validation of the general principles by other similar things? And there's a lot of similar things out there, especially when they're not patented. But, can you see publication peer-reviewed medical journals or presenting at rigorous conferences or whatever? That starts to give you an idea of how valid it is. And I'll go through each of the different conditions to give you some of the rundown on that. Because remember, it's how consistently effective it is going to be most relevant to ensure you've got the best hit rate and it was published. Is it patented? It's surprising how few tinnitus treatments out there are patented. And if it's not, it's obviously not novel enough or unique enough. Or it's not intrinsically worthy enough to even be patented. So I feel patenting is very important. There are some things which are not amenable to it, such as counselling, cognitive behavioural therapy, for example. But there's a lot of snake oil out there which hasn't had any patents, so I think that's important. Customisation is critical. I've got great data to show you the difference that customisation makes, and whether people are truly a specialist in tinnitus. That makes all the difference. But I do appreciate they are rare. And so this is why I'm trying to help everyone out by giving you a bit of a rundown. And a slight vestige, just so I repeat myself so much for every person. And so people might not even need to seek treatment if they know there are such a range of options. And they might be on the right path. This is what I'm trying to offer this series. And today is just the introduction to it. So in terms of, is this treatment making a significant difference? It's good to look at significance in terms of clinical significance as well as statistical. And I've long been an advocate for evidence-based tinnitus treatment and made myself a little bit unpopular in that regard with some people. But pushing for effect sizes to be published, which now, fortunately, is starting to become far more common. But certainly a randomised controlled clinical trial is the gold standard evidence for tinnitus treatment. But a lot of studies rightly talk about statistical significance, which is essential. But it's really, that's the odds whether the results could be due to chance or not, or it's more than chance, it must be significant. So it was great for a study comparing two different treatments. But sometimes you can have a significant difference between two groups, but it's only a quarter of a dB difference, which is statistically significant, but the patient's not going to hear it, so that's not clinically significant. And that's what I'm advocating we also look at as well as statistical significance. Being a clinical significance is how noticeable it's going to be. So this is how consistent the treatment is, and it's so critical for clinicians and, of course, the end users. And so calculating effect sizes is a way to get data to determine the clinical significance and be able to compare a level playing field. And so because of this, over the years, I've produced, with the help of my colleagues, a meta-analysis of different tinnitus treatments. I'll talk a wee bit about this. I want to go back to this when we look at the data and we start plugging it in. But it's like a common currency. So we can compare different studies, a level playing field, so we know how different the pre versus post therapy change is. And the Cohen's d is a very popular one that I like. And from this, we can use the questionnaires, pre-therapy, post-therapy, measure the change and measure it by the deviation, how much variation there is. And we get this Cohen's d effect size. And greater than 0.8 is substantial, 0.5 to 0.8 is average, 0.2 to 0.5 is minor, and 0.1 is trivial. So now we get to compare. And we first presented this and caused quite an uproar. Well, a lot of people talking about it. A lot of people said, oh, this needs to be done. It was in Valencia in Spain in 2013. And kept adding to it. And also the American Academy of Audiology, AAA, we started to publish a bigger database with what's Medline listed studies, randomized controlled studies, and useful numbers, questionnaires which are relevant. And so they rejected a lot of studies. So unfortunately, some of the better studies which were included and some of the worst studies we couldn't include it. But the headline for these, we'll go through these in more detail, is that there's actually very little evidence for pharmaceuticals or pills or supplements in randomized controlled studies. A lot of studies on cognitive behavioural therapy, but actually the effect sizes were fairly modest, which is surprising considering the hype surrounding CBT. Tinnitus retaining therapy is like controversial, but in these studies it did suggest that it was more effective than just masking, which is an older sort of concept. But it was the most consistently effective treatments in these studies. Were the ones that simultaneously address the psychological, audiological, and neurological components of tinnitus distress, which makes sense. If you're only going to hit one side of those three key equations, we're not going to treat it as effectively. With sound therapy of its various kinds, the effect sizes tended to improve over just counselling, and the more sophisticated sound therapy, the more efficient the treatment was. There wasn't actually a lot of robust evidence for hearing aids, mostly because they're relatively crude, but they're getting more tolerable, slightly higher pitch, etc. But there is a great place for a lot of people. But remember, we had to throw out most of the treatments, which were the worstly studied because they couldn't fit into that criterion. So anyway, we'll go through more of the treatments in detail coming up. But just to show you the headline, we can look at 2 months, 4 months, 6 months, and look at different treatments and whether the effect is trivial or minor. And say ginkgo biloba was just into the minor range, gabapentin just into average. But when we start looking at various neuromonics, whether independent or ones I did, we start to see effect sizes way off the chart. Different types of hearing aids. We can drill down to different levels and cup it down to different sort of hearing aids versus neuromonics. And you see off the charts is hearing aids which fully mask the tinnitus, etc. So, you can drill down further and further to start to compare the relative effectiveness of different treatments. So I haven't talked too much about the data. This is just the introduction to what we're going to talk about and a baseline for understanding the future question and answer topics. And please write in with any suggestions of things which you want covered if they're not already included. I certainly want to talk about linear because there's been a lot of hype about that. And the data is surprising. Brainwave TRX, of course, we wouldn't have heard about that yet because I've only just released that. Hearing aids, etc. There's a lot of different treatments out there, cognitive behavior therapy, etc. Much snake oil. So anyway, there'll be lots more to come. Today's the introduction. just wanted to warm you up to it and get you thinking about what you need to be looking at to know the efficacy of the treatments you're about to put your hard-earned time and money down on. Yeah, there's more information at tinnitusTelecare.com, and I'll be uploading this to YouTube, and I'll be sending out on my Instagram and things. I'll be sending out reminders of what's coming up next. So thanks for listening, and I hope you get something from this, and I'm looking forward to hearing all your comments and questions. Thanks for that. Bye.